This is Waves, a podcast from APTA Michigan. I'm Andy Wicks with Dr. Catherine Klein. Did you know that we all have pelvic floors? Even men? Okay, so I jest a little, but only a little. Dr. Alex Hill, perhaps better known on the internet as the OncoPelvic PT, is a gem of a human being who works at the intersection of oncology and pelvic floor treatments, a niche that may not be as niche as you might expect. She talked about the hows and whys of her career path and how she would very diplomatically speak to someone who cast aspersions on pelvic therapy. All right, Alex, please introduce yourself however you would like.
All right. Well, hello, everybody. I'm Alex Hill. I'm a physical therapist. I'm an outpatient, and I am in Jacksonville, Florida. I've been a physical therapist for a decade now, which is just
Congratulations.
weird.
Congratulations.
Thank you. Thank you. I feel like there's still a lot of days I feel like an early professional, but 10 years out, still don't know what I'm doing sometimes. And that's totally normal, you know?
Normalize feeling like you don't know what you're doing.
Exactly. Right. I was just on another podcast with DPTs of anxiety, and we're talking about just that, just like, who are you behind all of these things that you do, basically.
Yeah.
So it's awesome. Yeah, I specialize in pelvic health, oncology, lymphedema. I do gender-affirming care. I love lecturing. I love teaching. I love Michigan. I grew up in Michigan.
Did you really? I didn't
Where
know
in
that.
Michigan?
I did. Yep. I went to Rochester Adams.
Nice.
Rochester.
Okay. All right.
Yeah. So fun
Really?
fact, Madonna went to my high school. So that was exciting.
I like that you
Yep.
said Madonna went to my high school, not the other way around.
Yeah, obviously. I didn't go to hers. Hello. Come on.
That's awesome. That's hilarious. Very cool.
Yeah,
Well,
so-
welcome to a Michigander. I'm actually not a native Michigander. I'm a transplant, but I've been here long enough that I
You
feel
can
more at
claim
home
it.
here. So
I am
Awesome.
do. I
both
claim
a native Michigander and a current Michigander. So, yes.
we got all the bases covered.
I love it.
So, Alex, you're one of the many therapists that I have at least gotten to know of via social media, and then also talking with we've been doing this podcast now. In fact, we just had our 4th birthday. So again, happy belated birthday to the podcast.
Congrats
Thank
to
you. Thank you. We both, when I asked Catherine if we thought we would get here, and she without a beat of hesitation was like, no, didn't think it would last this long. Which maybe is Catherine's way of saying I want out.
No,
I don't
that
really
is
know
not
yet.
what it was. But like, if I think about how I got involved with this, which was literally seeing an Instagram post, I was like, APTA Michigan is starting a podcast. Message us if you're interested. And being like, sure, I'd be interested. And here we are 4 years later.
4 years later. What do I get
It's
myself
awesome.
into? But we've talked to enough people, and especially oddly enough, we seem to talk to a lot of people in the oncology sphere, and many of them have been like, you have to talk to Alex. You have to talk to Alex. You have to talk to Alex.
Well,
So here
and
we
I
are, we're
don't
talking
I
to
don't
Alex
think
now.
Alex knows my
Well,
I know you, I think, more than you know me, because you were an instructor at one of the
That's not
first
creepy at all,
pelvic
Catherine.
courses I ever took. You were an instructor there. And yes, yep.
Really?
And
So this had to have been in what, North
could have
Carolina?
been. It was I think it was level 2, I can't remember if it was level 2A or B with Herman and Wallace. It would have been like what, 5-6 years ago now. And then
Yeah, maybe
I
that's
think because
Texas.
I did
Somewhere.
take 2 courses in Houston. So I think it was one of those.
Oh, it was
Yeah.
probably Houston.
And then yeah.
Yeah.
And then I saw you speak at the APTA Pelvic Fall Symposium virtually, but or like the fall whatever they do. I forget the exact
Yeah.
title of it, but you were awesome. Yes.
Yeah. Fall Symposium. Oh, thank you. I'm very passionate about these areas of specialty practice, and I feel like they shouldn't be specialty practice. So that will be a soapbox
Yes.
that I get on tonight. However,
And
You know,
anytime,
that's
don't
awesome
feel like
that-
we got to wait for the end of the. If you got a soapbox, jump on it. It's fine. No one's going to tell you not to.
Yeah.
So your online presence is the OncoPelvic PT. So that, to me, as a lowly plebeian neuro specialist, that to me is 2 different specialties intersecting with each other that neither of which I know very much about. So if you could give us, a summary of how you landed here at the OncoPelvic intersection.
Sure. So I went to school at University of Florida, so go
I don't
Gators.
know if I can woo
And
for that or
I
not, but
first really got I'll take that. I'll take that. I mean, you're an original Michigander, so I'll allow that. During my first clinical rotation, I was in a outpatient orthopedic setting, and my clinical instructor was out for a day or two. And I was so curious what these pelvic therapists did behind these doors all day. Like, I would hear crying, I would hear laughing. Like, they'd come out and do like super cool exercises out in the gym. Like what the hell did they do all day? And so, like, I had to know. And so I shadowed with them, and it was incredible. Like, I'll never forget that first day that I shadowed. And hearing the stories that patients had gone through of dealing with leakage or lymphedema or whatever for months, years, decades, and being told it's in your head. Oh, you're having pain with sex, have a glass of wine. Oh, lymphedema and feeling like crap is totally normal after cancer. Like, and all it took was this physical therapist or a healthcare provider to stop, listen to the patient, put their hands on them, and educate them. And it was just so incredible to see the amount of change and empowerment that came from just one session of like, it's actually not in your head. It's an actual like
yeah.
physical issue that we can work on. And I just thought that that was so cool. And so for me, pelvic health and oncology were always together. That's how I was first introduced to them, which is a little unusual. And so I did a clinical rotation that was in, I'll put women's health because it was more pregnancy, postpartum, orthopedic, a couple kind of what we say true pelvic health cases. And from what I'd seen in my rotation at UF Health, where we had a lot of complex patients, a lot of diverse types of conditions that you would see, I knew that I wanted and needed more training in it. I was not going to be entry level in either of these areas with an 8-week clinical rotation and a couple-hour lecture in PT school about pelvic health. So as a student, I actually took my first level 1 course so I could do the clinical rotation and prepare for doing a residency. Applied to, I think, 5 residencies for women's health, because at that time there weren't any oncology residencies. Went to Duke for my women's health residency, and within the women's health kind of description of specialty practice, what's included in it isn't just women's health. It's really a misnomer. There's men's health, there's pediatrics, there's oncology. And so that kind of intertwining of pelvic health and oncology just continued on from there. And so I've been just doing this ever since.
That's awesome.
There we go. I think that's a great podcast. Thank you, Alex. That was fantastic.
All right, mic drop, we're done.
I already have lots of stuff. I need to seriously write some stuff down. I don't normally do this, but I'm like, okay, holy cow. But if you get, Catherine, if you got stuff you want to go ahead.
I was just going to say it is amazing how, like you kind of mentioned, neither one of those things are considered entry level, but I do feel like a lot of people that get interested in pelvic health or interested in oncology or have some sort of experience with that as a student. So I think your story does kind of highlight how important it is to at least have some exposure to these areas as a student, because it does kind of just open, whether it's pelvic and oncology or a different specialty area, it just kind of opens your eyes to like what all physical therapists can do.
Yeah, absolutely. And it's, and when I was in school, we had, like I said, like a couple-hour lecture, but even then it was more like red flags. How do you approach it orthopedically? And certainly like Ramona Horton kind of coined the term like pelvic health is orthopedics in a cave, which I love because at its right, like at its foundation, it is orthopedics, teeny tiny dark area.
That's funny. I also heard it as physical therapy in a warm, dark place.
Yes, absolutely. Absolutely.
But kind of as the dual specialty speaks to, like one of the things I really find fascinating about pelvic health is like you're kind of thinking about how every system of the body interacts with each other, because you have your musculoskeletal system, your nervous system, your lymphatic system, your digestive system, your, pretty much anything, cardiovascular, like it's all in the
Yeah.
pelvis. So
Yeah. And even with, research coming out on the interactions and the interplay between
yes.
like
Yep.
TMJ and pelvic floor, or like
Yep.
ankle foot stuff and pelvic floor, like how you walk and how that's impacting the pelvis itself, and muscular imbalances can then impact pelvic floor. Like it's
Which
so
I think,
fascinating.
to pull it back around, kind of points to every physical therapist should know about the pelvic floor, because if you're an outpatient physical
Yes.
therapist and you're working with someone who has a foot and ankle issue, they could be having pelvic floor issues too.
I just want to say the fact that you said getting a 2-hour lecture, I was like, I got a 0-minute lecture when I was in school. It was, I think I hope that I at least knew of the term like pelvic floor or women's. It was probably,
Right.
when I was in school, it was women's health because men don't have pelvic floors apparently.
No one besides women does now.
Yeah, but I certainly didn't remember getting any sort of lecture on it, and I know that most programs, if they can give you a module of any type, it's great. It's this is unfortunately the consequence I've learned. I transitioned to academia a couple years ago, so I learned quite a bit about the like curricular creep, or like if you want to add something in,
Yeah.
well, you got to take something out because we only have so much time,
Yep.
and every program's trying to make their programs more efficient and shorter, and adding new material doesn't help that. And the idea of what is entry level practice is, it's so frustrating because it's almost like, are we describing entry level practice as really like subpar practice because really you should know these things, but we just don't have the time to give you all of this information before the value of the education starts to become not
Yeah.
worth, as my boss likes to say,
Right.
the juice isn't worth the squeeze anymore. So
Yeah. Yeah. And I would say, you think about some of the things that we learn even in pelvic level 1, which is a
Mhm.
3-day course. One, you just don't have, like you say, you just don't have time to do that within the curriculum with how it's set up right now.
yeah,
And there's more and more requirements that are on the programs. I would argue that oncology, basic oncology care should
Yeah.
be entry level,
our former
right?
guest
We
would
have more
agree with
than,
you.
yes, I'm sure I'm echoing everybody else. And not even like that you need to know every single type of chemotherapy and what it does, and, all the things that you should know general safety things besides cancer itself as a red flag.
Yeah,
Like, that's not enough
yeah,
for PTs going out into care when we have over 18
Mhm.
million cancer survivors in the US.
yeah. That was a big. I'm just thinking again back to my own school. The only thing that I remember learning about oncology or cancer was that, yep, red flag, refer out. I'm like, oh, all right.
Yep.
Well, I guess I never have to worry about that.
I don't know.
I was able to interview Catherine. I still regret that you missed this interview, but Dan Steventon, so
Mm,
who is a
love
saint,
Dan.
maybe one of the best people in the
Yes.
world. But one of the
Yep.
things that he talked about was about the rate of cancer survivorship, because the rate of
Mhm.
survivorship is increasing so much. But also, I'm gonna misquote. I'll just say go back and listen to our episode with it because it's awesome. But the number of cancer survivors who will have some long-term health
Mhm.
condition then is that it, and it
Yep.
was I remember a shockingly high number. That yes, we're getting all these
Yep.
survivors, which is fantastic, but we're getting a lot of survivors who will have long-term healthcare needs as a result
Yep.
of this. So you kind of just touched on that. So
Yeah. Yep. That's
Can you
absolutely it.
talk about your practice a little bit more, Alex? Like, would you say you treat any type of oncology and any type of pelvic health issue, or is it primarily the intersection of oncology related to the pelvis?
All of the above. Venn diagram, I see
Okay.
all 3 areas. Pelvic health wise, I really see like everything right now. I do have a lot of people who are pregnant right now. I have a lot of people coming to see after
Mhm.
their prostatectomy, after their prostate cancer, gynecological,
Yep.
all the pelvic cancers. But also people just coming in who have prolapse and leakage and constipation, pelvic pain, pain with intercourse. I mentioned before, like I do gender affirming care practice as well. And then on the oncology, well, pelvic health wise, I kind of joke like if they're old enough to have like a learner's permit to drive, like I'll see them. Like kiddos in pelvic health, like I don't think I have the creativity to like
It
work with that. Like that's even more sub niche than what
it's a
pelvic
big
health
so
is.
that's my specialty, intersectionality is pediatric pelvic health. And I will
Yes,
say
yes.
it I mean, I love it. I think it's awesome, and it is super fun to be that creative, but going from because I started out primarily seeing adults, and then when I first started seeing kids, I was like, "Wow, I need to, like, really rethink how I'm structuring and educating and everything." Yes.
It's a whole new ball
The
game with that.
rules, the same rules
Yes.
do not always apply.
Yes.
Right. Right. Yeah. Well, kudos to you. Like I said, I think the youngest I've treated is like 11 maybe. But yeah, otherwise driving, you're awesome. And then for the oncology side, I do see primarily breast cancer, head and neck cancer, the pelvic cancers, then lymphedema. So I don't see a lot of like blood tumors or blood cancers. So just the nature of kind of where I'm at right now. So yeah, I see definitely a wide variety of things that can be anything from balance, deconditioning, strengthening, that kind of thing for oncology.
I think a lot of our listeners are students or young professionals. So for
Mhm.
them, if they're interested in either pelvic health or oncology or whatever niche area of practice, do you have any recommendations for like newer and or students getting like wanting to get their feet wet in either one of these areas?
So, I mean, we're in the age of technology now where there's so much available information out there. There's some really great resources in terms of like podcasts and social media channels just to learn more about what that specialty is. For oncology, Elise Cantu, she's the Onco PT. I actually listened to her podcast as I was studying for my boards for
Nice,
oncology,
nice.
but she has like a really great community to learn from. And then APT Oncology, we actually have a mentorship program that students can join, early professionals can join, and even therapists who are established but new to oncology and kind of getting their feet wet. They get matched with a mentor for either a 6 or 12 month kind of mentorship program. And it's really developed from oh gosh, when did we start? It's 2021, I think. So they've really developed it with a lot of different programming, a lot of leadership from the APTA and from academia come and do lectures for the students and for the mentors and mentees. So that's another really great resource. I believe APTA Pelvic, if they don't have one, then they're starting a mentorship program. But there's a lot of great resources. But also, just if you see someone or you hear someone, like if you're listening to this podcast and you're interested and just want to know a little bit more, send the PT an email. Like we are more than happy to talk to people about, if you need help finding a clinical rotation or if you just want to shadow for the day and you're trying to find somebody near you or just like, hey, what does this mean? Like we want more people in these specialty areas. So, I can probably speak for all the pelvic and oncology PTs that please email us and let us know if you have questions.
I would agree. I feel like the people who are in these specialties don't get too territorial about it, and they're more like, "Yeah,
No,
like, come on, ask me questions."
no.
And
Come to the doc side.
yeah, like, the oncology people especially, we've talked about this. I feel like I talked with this Adam Atachek.
I
Like,
think so. Yeah.
you don't get into oncology, like, because you're a jerk.
Yeah.
Yeah,
It does take a
no.
certain kind of person to work in that space, and they tend to be pretty cool people. So,
Yeah, it's really welcoming. They support each other if there's like collaborative studies that need to be done or working on project. I mean, everybody's super helpful, collaborative. Um, you know, trying not to be those kind of gatekeepers of information kind of thing that we can see sometimes. So
we do see that
that's always
sometimes.
nice too.
We do.
Yeah.
I have a quick question, Alex, because you talked about, so you did your residency at Duke, you said. It was, are they still called women's health residencies, or are they pelvic health now, or
So
what's the terminology?
it's women's health residency, and the board certification is in women's health. The section on women's health with APTA went through a name change. I was on the board when we went through that. So that was a very interesting time. It was very exciting. And so now that is APTA pelvic health, we
Yep.
wanted to be more inclusive with who we're actually seeing.
Yeah.
So APTA pelvic is separate from the board certification, which is the residencies and the board
Yep.
certification exam. That's through ABPTS. So unfortunately, that from last that I've heard is not looking at being changed
Okay.
in the near future.
Yep. Okay. When you were going through that process of applying for residencies, you said you applied to 5 or 6. I'm just curious, how many residencies for women's health were there at that time? And I'm curious if we know how many there are. I mean, I can look up how many there are now, but I would love to know if it's changed.
It has changed. I think there were like maybe 7 or 8 that were accredited when I applied. And this is, I mean, it was long ago, but it's not that long ago,
Yeah.
right? Like this was 11 years ago. I can't remember how many there are now that are accredited, but I know that it's at least double. Like I know that it's.
I'm trying to see if I can
the other
find the
one to
answer
say,
real
like-
quick.
I was like, I'm gonna do a little Googling
Directory
right
of
I know, like I was like,
programs.
can I
Let's
sneak
see.
and look this up? Because there's
Let's
accredited,
explore the
and then there's
directory.
ones
Who's
that
gonna
are
get there
in
first?
Mine's loading.
Right.
Okay.
I'm just gonna
I'm
trust
gonna
the
say
captain.
16.
Okay.
Oh, I don't want to find a specialist.
Accredited.
Oh, dang it. Oh, I went the wrong way.
I'm close. Cardio palm. It's probably all the way at the bottom. Women's health, 19.
Oh, man.
19
All right,
fully
that's close,
accredited.
16.
Yep.
So I mean,
So I'm guessing there's
There's a
probably some
lot more
in the
now.
process then of getting accredited. All right.
yeah,
I mean, that's fantastic. I think
But
we need more of them.
yes. And the other issue is in terms of like most of them are except one,
Yeah, I was just going to say, how many residents then does that
maybe
mean?
2.
Yeah.
Yeah.
So
So and there's even less for oncology because it's so new. I think there's like maybe I'm gonna say 6. I don't know, but
yeah,
but there are not a lot.
and I was just going to say, so I'm involved in a neuro residency here in Grand Rapids, and yeah, I mean, we take 1 resident a year, and while that's neurology, there's lots of neurologic residencies out there, but for these newer ones, yeah, that we're only graduating a handful of new specialists every year, and that's not even that's assuming they're going to take the test right away. So yeah, we need more. We need more. I have another question, but Catherine, I don't want if you want to.
No, go ahead. I was just curious. I was trying to find the oncology one to see how many, but I'm getting lost in all the orthopedic ones. That's probably what you're seeing in my eyes.
Those orthos, gosh.
This dang orthos.
You mentioned early on, so when you talked about your first experience shadowing with a pelvic floor therapist, because I chuckled because you're like, I heard screams, I heard laughter, I heard her crying or whatever. I'm like, I can imagine as a student, you're like, what the hell is going on back there? And
Basically.
do I need to call somebody here? I need an adult. But you spoke about the power of what I wrote down, the power of listening to the patient, getting your hands on them, and validating, essentially. And anyone who's listened to the podcast for any period of time knows that I am a big proponent of trauma-informed care. And I've also said that I feel like the pelvic floor therapists figured this out long before anyone else in PT was even aware of the concept, because I feel like they had to probably know these skills to be good at their job. And it's something that PTs, the rest of the PT world, is slowly kind of realizing, like, oh, there's some value here. The women's health and pelvic floor therapists, I feel like, light years ahead of the rest of us on that one. But I guess I just wanted to point that out and recognize that those techniques are valid in any setting, especially in the pelvic setting. But it's not, it's not limited there. It's not, they're certainly not gatekeepers. And like you said, they don't want to be gatekeepers, but they were the ones who they happen to just do it behind closed doors and recognize that. But the power of taking that time, acknowledging and validating that someone's complaints are real, not dismissing them. And then even if you did nothing else, that would still be a successful session. The patient would still walk out of
Yep.
there feeling like that was a good session.
And I
Yep.
Just
Absolutely.
wanted to touch on that.
to tie in
Yeah.
another level of it too, like you mentioned the power of touch and validating that something's wrong, and whether it's, I mean, I would argue that you're not a human. Like everyone has some degree of trauma in their life, whether it's capital T trauma or small t trauma. And whether you're dealing with a pelvic health concern or anything else that physical therapists treat, I think we can't underestimate the importance of giving someone the experience of a healing, helping, comfortable touch when they've had a lot of experiences with touch that didn't feel good or was threatening or was scary, or medical experiences that were scary or traumatizing for whatever reason. I think we have a lot of power to heal in that way too.
Absolutely.
Mhm.
And it's not even necessarily like a
No.
manual therapy skill.
No.
Like, yes, that's
Yeah.
obviously very important.
Right.
But it isn't, we're not talking about, oh, you just gotta, it's this particular mobilization. No, it's not that at all. It's the one of the OTs I used to work with gave, I don't know if she coined this term, but she used the term, the functional use of self, as essentially an intervention. And it's how she described what Catherine was talking about, like just being there. And maybe it is a calming hand on a shoulder, or maybe it is a whatever that is, but that is so powerful, so powerful.
Mm-hmm. Yep. And even, a couple thoughts on that, making sure that the patient understands that
Yep.
they're in control. Because so many times in the medical settings, they're not given
Yep.
options, right? It's okay, this is what we're doing. We're going to do this. I'm going to step out. I'm going to come in with 5 students and then ask you, as they're already in here, is it okay that they're
Yep.
in here? We're come
Yep.
on.
That was, I didn't have five people, but when I went in for too much information, everyone. But when I went in for my vasectomy, there was like an aide there. I was like, can they watch? I'm like, well, they're here.
Yeah.
So,
Right.
okay.
It's crazy. And Catherine, like you were saying, there's so much trauma and levels of trauma that can be experienced in different ways. With oncology, this is starting to get picked up more in terms of using trauma-informed care. Like getting diagnosed with cancer
is traumatic.
in and of it, like hearing those words can be so traumatizing for people. And then right after that appointment, okay, you have this appointment here, you have this appointment here, you have this testing here, you have this diagnosis here. Okay, who's going to be with you after your surgery? Like there's so many things that people are having to deal with. And then it's like, then they're dealing with what's called the survivorship cliff, which is they get through all their treatments, they get through all their appointments, and then, okay, no evidence of disease, you're good, bye.
Yeah.
And it's like, what?
And now you're just picking up the pieces of this person that's been in fight or flight for however long.
Yeah.
Oh my gosh.
Yeah. It's
Here, ring a bell.
How, right. You're done. Trauma's over. It's just crazy. It's just crazy how our healthcare system works.
Oh my gosh.
But this is one of the joys and like why I love being in PT and being in rehab is like, we're with them every step of the way. Like we help them understand like, oh yeah, this is a normal pain. This is not a normal pain. Like what is, and I hate the term, but like, what is your new normal? Like post-cancer treatment, so.
No more trauma.
Right. That'll be the tagline for this episode.
God. Every time I watch one of those videos now, instead of getting the warm fuzzy feelings like I'm supposed to, I'm just gonna be like, no more trauma. It's all done.
Tie it up with a little bow and lock it away like it never happened.
Yep.
All right, Alex, you want soapbox time? You want to do it?
Ooh. There's so many things that I could get on. I mean, honestly,
you're not limited.
Like I feel like we hit most of them in terms of like pelvic health is universal. Even within pelvic health, like we work with neuro patients, people who have Parkinson's, spinal cord injury. Like it's it's universal, and it should be something that is not just a
Yeah.
red flag screen for, do you have bowel or bladder or sexual issue? Like, you got to ask these questions and
God
then
forbid you
follow
say
up
those
with
things to a
it,
patient.
right? Uh, Clutch my pearls, right? Like, you can't, like, if you are nervous or showing that you're nervous or uncomfortable asking the patient these
Yeah.
questions, they're going to be uncomfortable answering the questions. Like, this is one thing that I feel okay telling people, like therapists, like, fake it till you make it, that you're
Yeah.
confident asking these questions. Like, practice with your dog, practice with your pillow, like, practice your wording that you can use, that it's not something that's from left field, that you're working with them for balance for Parkinson's. And you're like, oh, hey, but also, like, are you having some constipation? Because that's pretty common with Parkinson's, right? Like, you need like a little flow with it
Yeah.
to like make it
Yeah.
like normalize talking about your pelvic health.
And I
That's
would
funny. I mean, that's such a great thing. It's just practice in the mirror. I love
and
it.
I would also
Yeah.
fully encourage you to just start talking to your friends and family about it too. Because because one, you'll find out that a lot more people have issues in that arena or just don't know how things are supposed to work. And then you just and then it does feel like it's just a normal conversation to have in everyday life because you're having that normal conversation in everyday life. And people love,
I mean, if you can ask your parents about it, and get through that awkwardness,
mean,
imagine how easy it's going to be to ask your patients.
Oh, we talk about this most family meals.
Nice.
Something pelvic health related generally
And
comes up.
Who had a
To
good
be-
poop today? All right.
to be honest,
Yep.
one, if you bring it up, people love talking about it. Like,
They
just
do,
looking for
because
permission.
they have
Yes.
these questions themselves. They don't know what's normal or not. And like, they saw an influencer
Yeah.
online that said doing whatever is gonna cure your incontinence. Like, what
Yes.
the hell are you listening to? Like, no. No, it's I agree. Like, as soon as you open that door for people, like, it's huge. That's so I actually, with my business, so I have a QR code on my
Nice.
pop socket. So I just ran out of hands at CSM one year. I was like, okay, I need something easy to just
That's cool.
scan people.
That's neat.
Yeah.
We need to get those
We
guys.
But
do.
I've had it right, super easy. Design it yourself, pop socket,
Love it.
no affiliation, just awesome.
Love it.
But people see like, oh, it's like a pelvis and a cancer ribbon. Like, when's that for? Like, I've seen people like scan it on the fly. And I'm like, it's okay, here, like, scan it.
That's funny.
But like then they like ask what you do, and then you start talking in there, and they just get so intrigued by it because again, it's just something that
Mhm.
everybody has a pelvis. All majority of people are going to have some type of pelvic floor issue in their
Yes.
lifetime. Like,
Yep.
let's talk about
Like
what's normal and what's not normal.
to
Yeah.
be honest with you, have never had a conversation with someone about their pelvic health where they were like, ew, why would you talk to me about that? Like, they're very, people are very, like you said, very willing to talk about it if you ask.
The societal
Yes.
we is not willing to talk about it, but the individual I is willing to
Yes.
talk about it. Isn't that weird?
Yes. Yeah.
Weird.
But that's what we're trying to change, like,
Mhm.
social media and just grassroots effort of
Yes.
normalizing pelvic health. Starting from the bottom. No pun intended.
You've never said that before, have you?
I actually haven't. I'm not.
I was
very
gonna-
I say,
punny
Alex,
quick. I
don't
was
lie
gonna
to us.
say-
That
came
was
from.
that pun was firmly
Wait,
intended.
I was gonna say, was that a Drake reference? Because I feel like there could be like a started from the bottom, now we're here, like pelvic health kind of thing.
Ooh. All right, I'm writing that down for
Maybe you
next
need
year.
as
Yep.
a
I will
new
credit
theme
you.
song. New theme song.
Right.
Oh my
That's
goodness.
a really good idea.
Oh, all right. Okay. That's too good.
The fun you didn't even know you're going to have on this
You know,
podcast,
I've I've been around the block enough times, and especially learning anytime I have a conversation around pelvic health stuff, which it's mostly with Catherine, let's be real. But I've also just kind of expected like this is gonna go in places I wasn't
But you
expecting.
love it, right?
But I've never not enjoyed it. So
But it's, it's really cool to see, in the 10 years I've been practicing, like how much more it's getting recognized. Like I remember there was an article in Oprah like 8 years ago, and it was this huge thing because she talked about like pelvic health, or like Megan Trainor talking about and like opening up about vaginismus and her pain with sex. And it's like it's getting to be more normal to talk about it. So more people, one, can recognize like, oh, I need help. And then
Mhm.
two, I can get help,
Yeah.
right?
I'm
Like
Yes.
not the
what
only
we do
one.
in PT. Yeah, exactly. And that's not to say that we don't have a lot of people that come in there like,
Yeah.
I don't know why I'm here. This is weird. Like, what are you doing? Kind of thing. But then once, like, you explain the anatomy and you explain what you do and, like, talk about their symptoms, then they're on
Mhm.
board. It's building that therapeutic alliance of them understanding what you can do for them to help them, and then they're on board. But, like, that's still
Yep.
very common. I'm sure, Captain, you get this too, that people come in, they're just like, "This is weird. I don't
Yep.
know what this is. My
Yep.
doctor told me to come."
Yep.
I mean, I think we see that in any setting, but in this setting particularly, you really got if you don't have that trust,
Well,
then
Right.
and
it
I
ain't
think
going anywhere.
just
And
just to return
Right.
to something that I think pelvic health therapists do well that I think applies to every specialty area is, like you said, Alex, getting the patient to really understand the anatomy and how you can help them and why it's important that they address these issues that they're having.
Yep. Absolutely. Getting it back to their
Yep.
goals, their functioning, right? What's that quote? We put the doctors give the
Yep.
years of life, but we put the life in the years in rehab. What's
I've
that
heard
quote?
it. I've heard
something like
it.
that. That's something like that.
We put we're putting a
But what you're talking about, and this is for my students specifically, saliency and specificity. These
yep.
are the principles of this is the Climb article that gets referenced all the time. And it's looking at neuroplasticity, but really it's good clinical work here because make it specific to the patient, make them value it, make them want to do it. That's how you're going to
Mhm.
get success. That's how you're going to build
Mhm.
neuroplasticity. It's how you're going to build adherence to the program. That's how you're going to build good outcomes with your patients, no matter what the setting,
And that's
especially this one.
always And
Look at
that's
this.
Yep.
always true no
Absolutely.
matter if it's the quote unquote easiest person, like easiest diagnosis, or like the most challenging, complicated case you've ever seen.
Yep.
Oh man. Any other soapboxes? This is great. I love it. We're doing great here.
Gosh. I don't even know where to go with
What if
this.
what if a student came up to you and was like, pelvic health therapy is dumb?
You're dumb. I'm just kidding. I would never say that.
Oh, you almost got Catherine. That was great.
I would never say that. People that know me knows that I would never say that.
All right. I'm gonna say this now. If anyone sees Alex at a convention or something, I want you to just go up to her and say, pelvic floor therapy is dumb.
That
And just see
that's
what she
you
says
need a
back.
new pop socket, Alex, that just says, "You're dumb."
So I would probably respond respectfully. You're dumb. No, I I would. Something like that where it's not just a what is this kind of thing. It's just like an outright like this is dumb. Like why do we need to go through this kind of thing? I would just ask, what do you know about it? Because a lot of times it's more of just like someone doesn't fully understand like what we do or how they can apply it to their population. So not picking on like sports and ortho, but like your athletes especially your female athletes or your athletes with vulvas, like they're probably having some type of leakage or
Yeah.
some type of pelvic floor disorder that they are hiding in some way. I've worked with enough athletes that have worked with PTs in the past for their ankle injury or knee injury or anything like that. And, never screened for pelvic floor, never screened for RDS. Like they're just like, don't be so hyper focused on the knee quote that's coming in to see. Like you really need to look at
Yeah.
whole body, pelvic floor is included with it. So really, like I said, I would just ask more. What do
Yeah.
you know about the
That's a
pelvic?
very diplomatic way. It's a much better way
Saying
of saying you're dumb.
right.
So and that's you. So I'm going to tie that into something because the this hypothetical student that I'm presenting to is coming at you with almost a little bit of anger and like they're being antagonistic, like by saying this
Yeah.
is stupid, this is dumb, I don't need to learn this. And to me, that's in the same category of emotions as like anger to me. And anger is
Mhm.
not a primary emotion. We're not angry because we're angry. We're angry because of something
I was
else,
gonna
because we're scared, because we
Mhm.
I was
feel
gonna say,
threatened.
that makes me wonder, why are you so uncomfortable talking about pelvic floor?
Exactly. So, and really, what that's saying
Yeah.
is that the student is
Yeah.
uncomfortable and feels threatened, and I want to know
Right.
what's going on. Like,
Mhm.
Yeah.
what happened to you? You know,
Yeah.
but
Yep.
it can be very satisfying in the moment to just say you're dumb. So,
Right.
privately, inwardly, you can say that.
Yes.
Outwardly,
Outwardly, what's actually going on? What do you know about
yeah,
it? What are your, Yeah. But yeah, I agree. It's usually coming from someplace else, right?
yeah, and it's, I mean, and I see this in academia sometimes, because while I think everyone should be a great neurotherapist, I understand not everyone wants to go
Mhm.
into neuro, and that's fine. I get that, because I'm
Mhm.
glad there are people who want to go into orthopedics and stuff like that, because it's not my jam at all. But
Yep.
it's, if you come at the topic with some antagonism, that's like, all right, well, something's going on here where it's beyond of just boredom and apathy.
Mhm.
And
That's a
well,
different
Yeah.
and
that's a
I would
different side
argue
topic.
that children with
Yeah.
cerebral palsy grow up and become adults with mild, like, if they have mild cerebral palsy, they sprain their ankle, you're seeing them in an outpatient orthopedic clinic, like, that will happen.
Yeah,
So, you need
Yeah.
to know things.
there is no neuro patient, there is no ortho patient. They all have
Right.
respiratory systems and musculoskeletal systems.
Right. They all have all the
They have
things.
all the things. We need to treat all the things.
Yeah.
Oh, anything else you want to talk about, Alex?
The the antagonist viewpoint brought up for me, like I said, I do gender affirming care. That can be
Mm.
a very polarizing topic for within and
Yep.
outside of
Oh
healthcare
yeah.
as well. A lot of people don't realize what all we can do in rehab to help people who are doing, any type of gender affirming care. A lot of people think of it as only doing surgery, either a top or bottom surgery, but there are so many other ways that people can utilize non-medical ways to help with their gender affirming practices. So things like doing chest binding. If you think about, doing chest binding, how much that constricts the ribs, that impacts their posture, their breathing patterns, can cause a lot of musculoskeletal issues. And so for me, in terms of like what we do in rehab, we owe it to our patients and our profession to
Yep.
treat anybody that comes in the door. And it's still at the end of the day a musculoskeletal issue that could be occurring. So I would say that would be one other soapbox that I get on as well.
Do you feel comfortable talking about, because I do think there is varying degrees of resistance within society and within healthcare. I guess to follow in Andy's vein of what would you do if a student came up to you and asked pelvic floor is stupid? What would you do if another therapist came up and said, I'm not comfortable working with someone who's transgender? Or why would I learn how to do that? Or et cetera, et cetera.
I've been in this situation before. So it was kind of like what Andy suggested earlier in terms of tell me more. Like don't I this isn't about me and me treating them. This is about you and your beliefs, your treatment, and your healthcare beliefs as well as a provider. So it's kind of dialing it down a little bit and like, well, let's
Mhm.
have a conversation about it. Like let's go to a private room and like just talk about it and have it as more of a conversation of like, are there things that you're uncomfortable with? Like, is it their lifestyle? Is it, like what is it that you are not
Yeah.
comfortable with or that you don't want to treat? And so it was a productive conversation, but again, I feel like with a lot of things right now in today's world, everything is so polarizing and people are so
Yeah.
quick to come to arms and just fight without actually hearing and listening to the other person and really understanding where they're coming from. So like once I understood where this person was coming from, then we could kind of talk through like, okay, well, it's actually that you've never met somebody who was transgender. You maybe did the one cultural competence course that we needed to start working here
Yeah.
and have your license and all the things online. So it's just getting a better understanding of where they were coming from and kind of working through that and then, helping improve our cultural competence as a clinic doing in services going through with front desk, what to do when a person who their gender doesn't match what is in our medical record system, or their name doesn't match. Like, how do you navigate that? A lot of it's just unknown to people on how to navigate it. And so that's scary for whatever reason. But if we learn and talk and have it as a safe space to learn, that can be really empowering. I did not tell them that they were dumb, for the record.
I believe you on that one. I believe you on that one.
It's all just coming from a place of understanding, right?
Yeah.
Like, again, if someone's coming from one of these secondary emotions, it's where is that actually coming from?
Yeah.
So
I've told the story before. My first boss gave me some fantastic advice when I was starting out with talking about dealing with difficult patients. And in our settings, I worked in a TBI clinic of like violent patients, but it takes two to fight.
Sure.
So if you don't fight with them, there's no fight, because if they're not mad at
Like
you,
that.
they're mad at something. You just happen to be the person in front of them. So if you can help them figure out what they're mad at, then you can talk about it. So.
Mhm. Yep. I like that. It's absolutely true.
Fantastic. Alex, we've kept you for nearly an hour. You've been very gracious.
And I've had so much fun.
Well, I'm
We
glad
have
you've
had so
fun.
much
We've had
fun.
a blast. I've had a blast.
That's like,
This has been great. Where can people find you if you want to be found?
I was like, if I want to know.
You already told everyone they
Please
could
find
email
me.
you,
I
so
love getting.
no take
That's true.
backs.
I did. I can't backtrack on that now. No, I really do love when people like email me like, hey, I heard you on XYZ podcast. And I always email whoever's podcast it was and like let them know like, hey, like we got this connection for you. Because I think that's the amazing thing about human connections, and like it's just I love it. But OncoPelvic PT is my side company that I'm full-time clinician at our hospital system. That's OncoPelvicPT.com, Twitter, X, whatever it is, Facebook, Instagram, TikTok.
We'll link to all the things.
YouTube. All the things.
Very cool. Yeah. So if you aren't familiar with Alex, if you don't follow her on social media, I highly recommend it. It's good stuff. It's worth your while. She's good people. Alex, thank you for being on the podcast. Thank you for taking an hour out of your evening to talk with a couple Michiganders. We very much appreciate you.
Absolutely. We're going to do a screen airify
Yeah,
with
Michigan.
Yep.
Dr. Alex Hill is a double board certified clinical specialist in both oncologic and women's health physical therapy, and is a certified lymphedema therapist. In short, she knows what she's talking about. Links to her website and social media profiles can be found in the show notes. Even though she lives in Florida, she'll always be a Michigander at heart. Waves is a production of APTA Michigan. It is co-hosted by Dr. Catherine Klein and me, Andy Wicks. This episode edited by Bracken Busker. Dr. Bridget Hammond runs our social media, and Dr. Molly Fagan is our scheduler. You can find us online at www.aptami.org or on social media at aptamiwaves. If you're the reviewing type, we would be forever grateful if you would leave us a review on your podcatcher of choice. It's true what the podcasters say. It really does help get our show in front of more people. As always, thank you for listening, and may your documentation always be done on time.